So what do we hope that all this is going to achieve? Well, we'll have patient cohort and associated biobank, and out of that, we believe that we'll identify different novel subtypes of severe patients with severe asthma, so that we'll be able to better understand their profiles, be better able to understand how we may manage them, and better understand how we can target therapies that are more likely to actually work and meet the unmet needs. By following the patients over time, then we'll be able to better validate the different handprints. So the idea is that we'll start off with different profiles, but over time there'll be an iterative process while we better validate the different handprints, so that ultimately at the end of the project we'll have a robust assessment of different patients' subtypes. We'll also be able to look at patients in an exacerbation setting, and also we have kicked off some different preclinical and clinical models work already, and we'll be able to from the start look at the linkage between findings in those models and what we find in man as well. We kicked off work already to establish an international consensus on diagnostic criteria, but then again, once we better understand the disease, then that'll be refined, and hopefully we'll have a more definitive picture for making those diagnostic criteria. And importantly, this is I think that this is a large consortium. It's really established a fantastic critical mass for people with an interest in the area to get together and advance our knowledge of the disease. And ultimately, yeah, it's all about us better understanding patients, to be able to better manage patients, diagnose and manage patients, and most importantly, to get new therapies to patients. And we've achieved a lot so far. I think the collaboration's been excellent between the partners. You know, we've had problems that have arisen during the way, challenges that you get with any large project, and we've worked collegiately, and we've addressed those as we've been going along. It's not really tension between FPIA and other parties. It's more about the sort of things that you find as you're going along on any large project, challenges that have to be addressed, and we've worked as a team to do that. We had one of the first major deliverables back from June of 2008 to agree the diagnostic criteria for severe asthma. So that's but that was a necessity to inform the protocol, entry criteria for the protocol. We officially went live in October of last year, and the different work packages have all progressed according to schedule. We've finalised the protocol pretty much with a view to starting the actual cohort study in October of this year. And we recently launched our website, again talking about the contribution of different partners. I mean, this was a website that would have been really not possible in the time frame if it hadn't been for the involvement of our different partners from the patient associations, particularly the ELF. I'd urge you to take a look at the website. We're quite proud of it. We think that it's an excellent communications vehicle for us, and I think it sort of clearly states our aims, and a lot of that's thanks to the patient associations who've been intimately involved in Work Package 9 in particular, as well as others. The intent of this is just to really show our sort of project plan through to around Q2 2010 here. So it shows that across these different domains, then we've had progress to schedule, and then we'll be going off into the back end of this year and beyond for some of these other activities here. We have had a publication already. This was recently published in Chest with Charles O'Frabe and other colleagues from the consortium, looking at an integrated systems biology approach to understanding pulmonary disease, but really with specific reference to U-BIOPRED. And again, that consensus meeting, looking at a diagnostic criteria for the disease, has resulted in a publication that's being progressed presently. So we've made a lot of progress already. I think feel very positive about this consortium, and I really feel that we have got the right people to actually make a difference and realise the aims of the project. As far as funding is concerned, then we have nearly 9 million euros from the IMI, just over 10 million euros from FPIA. Total project costs over 20 million euros. And as I mentioned, the project started in October of last year. Typo there on the slide there. It's scheduled to run for 5 years in total. Peter Sturck is the coordinator for the project. I'm the FP lead. Our contact details are here. Again, that's the website, so please take a look at that. And more than happy to take any questions that you may have. Thank you.
Any questions?
Thank you. I think it's a very nice study. It's lovely to see all the different aspects of biology and medicine coming together. But I'm quite interested in how you've done your sample size calculations and what you're powered to actually see. Because the epidemiologists I work with want me to do like 100,000 patients, and there has to be obviously some kind of compromise. So what are you actually powered to see within that 500 asthma patients?
That's a good point, because obviously the whole idea of this is that it's unbiased. So you want to actually look at a profile of a whole range of different outcomes and consolidate that knowledge using knowledge management techniques. So, you know, effectively we've sized the sample on what we felt would be practical. Rather than any formal power calculations based on one particular endpoint, because we're looking at such a wide range of different endpoints, it's really impossible to just pick one.
Okay. Any other questions?
So, Scott, whether you want to make any comments on the challenges that we faced as we've been going along, or any sort of
challenges that you pointed out have been many, but I definitely reflect that there's been, as you point out, a degree of synergism between the EFPA partners and the academia. Our biggest challenge is one of the biggest challenges is the size. It's 39 partners and right now 208 contacts. So we've really had to focus a lot on trying to use the latest technology and online collaboration tools to make it all come together, and to really try to streamline our communications. And I think the biggest thing is getting everybody together frequently through TCs as a forming exercise, and I think that's worked very well. Because now I think we're very efficient in addressing
yes, absolutely.
new issues.
A really cohesive group.
Any other questions? I still may have one, Chris.
Let's go ahead.
So the patient organizations that are involved,
yeah.
Can you give some examples of the contributions they make and the tasks that are assigned to them?
So the patient organizations are actually involved, across all the different work packages, clearly, particularly the clinically orientated ones. We have an ethics board which is actually led by Pim de Boer, so it's actually led by someone from one of the patient organisations. As I mentioned, the communications work package is very well represented by the different patient groups, and that website I don't think would have been as good or happened in such a timely fashion if we hadn't had the patient groups involved. But also when it comes to the protocol design, reviewing the protocol design, the informed consent, all those different things where you really need patient input and contribution, we're getting it, and part of the scientific board represented there. So represented not just in the work packages, but also in the sort of the infrastructure that's organising and driving the project as well.
Okay, so has that thrown up some surprises in terms of protocol design?
No, I don't think it's
no?
thrown up any surprises, but I think we've had candid discussions about the way that the protocol is designed and the different procedures that the patients need to go through for their assessments. So I think it's added value, but I don't think it's actually thrown up anything that hasn't been insurmountable.
Not that you were going to do it totally different.
It's got a problem.